I'm delighted to introduce Trish Idensohn, who is an independent wound consultant, and she's going to be talking to us about, can we predict wound healing? So it's a subject I think all of us want to ask that question when we're looking after people with wounds. So thanks, Trish. I'll hand over to you now. Thank you.
Thank you very much. Hi, everybody, and thanks for everybody in the chat. Well, can we predict that this was going to happen today is probably as big a question as I can ask as can we predict wound healing? Before I start, though, I'd like to just say hello to everybody and thank Sarah, the trustees and the Society of Tissue Viability for the invitation to present today and their patients. And I'd like to disclose I have no conflict of interest and consent has been obtained for the photographs that I'll show you of some of my patients today within the presentation according to the POPI Act of South Africa 2013. So the big question is, can we predict wound healing? And I'm sure some of you are thinking, well, what does that actually mean? What does it mean to predict? Well, could I have seen the future today where my service provider went down? Can we see the future today if this wound, the picture on the left, is going to advance to the picture on the right, or this wound status on the right? So what does it mean to predict the wound healing? It's to assess the patient with relation to the possibility of his wound healing. Is this wound going to heal? What is the time frame it'll take to heal? And what are the factors? This patient has obesity, hypertension, and diabetes influencing the wound's advancement towards closure or complete recovery. And then we call these, they're referred to as prognostic factors. Sorry, I don't know what's happening here now. Can everyone still see my screen? Hello?
Yes, I can see your screen.
Okay. All right. So what we refer to these as prognostic or predictive factors. So they're the same words, just same meaning, just different words. And it's important that we have early detection of delayed healing of wounds. And these predictive factors can assist us as clinicians to optimize our treatment strategies, improve our patient outcomes, and allocate healthcare resources effectively to reduce the costs. So when we assess time frame to heal, regardless of what method we use, we are generally calculating measurement and working out the percentage area over a time period to predict, to provide the predicted or the evolution of the wound itself. And I'm sure most of you are aware of this, that there are a variety of measurement methods, including a simple ruler method, mathematical models, manual and digital planimetry, stereophotogrammetry, and digital imaging methods. And these are all included in a systematic review that's quite recent. And they were put in the systematic review to evaluate their accuracy, agreement, reliability, and feasibility. Both the contact and non-contact 3D technologies had low accuracy, high cost, and were complex to set up. I think because they're just so cumbersome with these big models that you have to put the fluid or gel into the wound. Digital planimetry and digital imaging were considered the most accurate and reliable methods for area measurement, particularly in irregular shaped wounds and very large wounds. But these methods can also be time-consuming in clinical practice. So due to this, in the systematic review, they actually recommend that when requiring a very fast method, to go back to the old-fashioned simple area measurement method for circumferential wounds. And that is taking the longest length by the widest width, and that is taken perpendicular to the length. I'm going to ask you, when we look at measurement versus time frame, have you ever heard of the keratinocyte speed limit? And do you know what the speed limit is? It's the rate of healing measuring the advancement of keratinocytes from the wound edge of less than 0.75 millimeters per week. And that's linked with poor diagnosis. So anything under that is poor diagnosis and failure to heal, so poor prediction. Whilst with a greater than 1.5 to 1.5 centimeters per week, That's 6 millimeters in 4 weeks, sorry, 6 centimeters in 4 weeks. That has not been able to be achieved even in healing wounds. And although this was published by Falango in 2008 originally, recently in 2022, he's published this again. I have to say, though, that within my personal experience with advanced technologies, we can actually reach more than this amount of healing within our keratinocyte speed limit. So if we look at measuring percentage reduction in ulcer area to time frame, a 50% reduction is evidenced in ulcer area after 4 weeks to be a good predictor of wound healing. Wound size and surface area, depth, and wound duration being amid the most common predictive factors in complex wounds is a good indicator. And wounds with a larger area, and this is quite interesting, are associated with reduced risk of delay in the healing process per unit of time compared to smaller wounds. So you wouldn't think that, would you? When we look at larger wounds, you think they're going to take a longer time. Individuals with neuropathic wounds less than or equal to 2 centimeters squared, or less than or equal to 2 months old, and wounds of grade less than or equal to 2 of the Wagner scale are also good predictive factors of wound healing. But the truth be told, recently this year, Smith et al. Published that there's no international consensus on the anticipated time for any wound to heal. And more research is actually needed on the actual healing times. So when we speak about clinical assessment tools to predict healing, you know, what else are we going to use? So we have an assessment and you minus 1 week's measurement from the others. But when we have a look at a systematic review by Smith et al., he looked at clinical assessment tools and said that there was a lack of consensus regarding the key elements required. He took 14 tools from 27 publications, and he said that most assessment tools were based on low to very low quality. And although the PUSH, that's the Pressure Ulcer Scale for Healing version 3, which can be used for all chronic wounds, and the photographic wound assessment tool, as well as the revised PWAT, were only 2 based on moderate to high quality evidence to be used for the purpose of assessment only. They categorically state that they do not recommend these either for wound healing prediction, despite them monitoring wound improvement or deterioration. So what about the use of artificial intelligence and machine learning? Well, fortunately, machine learning models can accurately predict chronic wound healing time. If we take the record data from electronic health record data, and the NHS have great access for this, in these 2 current studies of machine learning, electronic health records describing patient demographics, comorbidities, and wound history, wound characteristics were captured. And this came out with the top influential predictors of wounds at risk of not healing, as well as healing, being days in treatment, wound depth, location, and wound area, so all local factors, being the most influential predictors of wounds at risk of not healing and healing. And these being more powerful predictors than patient demographics, as well as comorbidities in study 2, which is the one on the right. More excitingly, though, that personalized healing trajectories are becoming possible with the introduction of technology values, and these can give us insight into how specific patient-specific variables influence our predictions. Another way of predicting wounds is using predictive biomarkers for wound healing. Unfortunately, the shift to clinical point-of-care technology from the laboratory needs to focus on being simple and economical, but many promising biomarkers using different methods of sample collection are in development. A study in 2017 resulted in increased levels of matrix metalloproteinases, MMPs, and exudates from non-healing wounds being linked with reduced healing rates. But in 2018, Cochrane Review highlighted uncertainty and low validity of evidence on protease activity as a prognostic factor for wound healing in venous leg ulcers. So just when we think we have something, Cochrane says no. So here's something that's more positive. pH and temperature biomarkers can be easily used at the bedside to predict wound healing, and these are relatively affordable and easy to utilize. The pH and the temperature changes as the wound progresses. The pH becomes acidic, and the temperature decreases and increases when the wound stalls, and the pH then becomes alkaline. The degree of change in the pH and temperature indicates a healing or non-healing wound, and this is really easy to do. Kevin Wu very recently has, last year, in a retrospective single-centered, non-randomized and observational study of 84 patients, so it's a small study, came up with the result that TCPO2 value predicted wound healing of ischemic lower extremity injuries. The cutoff value of the TCPO2 was determined at being 40 millimeters of mercury for predicting wound healing. Higher TCPO2 values are associated with shorter healing times. So taking a look at acute wounds and chronic wounds, we know that wound healing is complex and it's a biological process influenced by various factors. And amongst many characteristics, the acute wound, in this case, being the incision and drainage of a cyst on the liver on the left, usually has predictable healing, whilst the chronic wound on the right, in this case, Fournier's gangrene, with underlying pathophysiology of diabetes type 2 and chronic inflammation as well as infection, has unpredictable healing. In the developing world, a poorly managed acute wound is the most common cause of a chronic wound. This patient has hemosiderin staining, indicative of chronic venous leg ulcers, or chronic venous, I should say, in hypertension, and requires compression. Without compression applied postoperatively to this wound is at increased risk of becoming chronic. So perhaps you are the practitioner who's discussing and/or planning elective surgery with this patient. Can you predict the healing of the acute wound prior to surgery? Can you recognize the risk of delayed wound healing pre-surgery? And do you have the solutions for addressing these risks? To prevent acute wounds becoming chronic, one should always be alert to pre-existing conditions pre-surgery. That is why, and I'm going to stress this a couple of times this morning, that taking a comprehensive medical and surgical history when planning surgery and even on first assessment of a chronic wound is absolutely essential. Bain et al. In 2020 recommends that healthcare practitioners should be cautious in their approach and exercise care with high-risk patients for surgery, considering permanent rather than absorbable sutures perhaps, maintaining skin closure for longer than usual, antibiotic prophylaxis, which the IIWCC document also recommends in high-risk patients, and if time permits, correction of nutritional deficits before surgery. The UK National Wound Care Strategy document regarding surgical wound complications provides a pre, intra, and post-operative care pathway, and that includes addressing risk factors pre-surgery. So the third factor is factors that we need to look at when we predict healing are the factors that impact wound healing. And these have varied etiologies and numerous factors, including comorbidities and lifestyle factors, impacting the healing rates, making wound healing prediction challenging and difficult due to the variability. Many comorbidities can impact wound healing, especially those that impair oxygenation and perfusion, cellular transport of nutrients, endocrine function, immune responses, tissue repair and regeneration, and psychological responses to wounding, for example, pain. The common factors, though, that delay wound healing, these are the most major factors that we'll discuss, are genetics, chronic disease, aging, medication, hypoxia, infections, stress, smoking, alcohol, nutrition, and sex hormones. Did you know that? When we look at genetics, there's things like keloid scarring, which is a wound repair condition I'm sure you're familiar with, and it's more common in African, Asian, and Hispanic ancestry, and minor occurrences in Caucasian population. There's Ehlers-Danlos syndrome, which is defective connective tissue and collagen synthesis disorder, and it's characterized by skin fragility, hyperflexibility, joint hypermobility, and impaired wound healing. EB, epidermolysis bullosa, is a group of genetic skin diseases characterized by fragility in dermo-epidermal junction and separation of the cutaneous layers, and this results in blisters with impaired healing. Osteogenesis imperfecta and Marfan syndrome are other genetic conditions, and with genetic conditions, we predict that the healing, if they're not controlled with other factors, is going to take longer. One of the big major factors I think that we really need to be aware of assessment of our patients and in managing these patients are the main chronic diseases that delay wound healing in different ways, and these are them. It's important to recognize them and address these systemic diseases to prevent delay in healing. For instance, with respiratory, there's chronic obstructive pulmonary disease, congestive cardiac failure with cardiovascular comorbidities. Baseline investigation should always be done, and we should never underestimate doing vital signs at every visit of the patient. It's amazing, you can pick up hypertension, irregular pulse, dyspnea, hyperglycemia, and body weight are but a few factors and variables that should always be included on an assessment, not just the initial, but should always be done on continually on seeing the patient. As with experience, I'm sure you're aware, one can become diabetic midstream of wound management. So these should be addressed and documented on admission for sake of communication with other healthcare practitioners too. We need to always monitor the blood glucose control in clients with diabetes mellitus, and on admission, we should always do an HbA1c and review that every 2 to 3 months. If patients are obese, a weight loss program and encouragement for these obese patients to promote wound healing and prevent delay are a few examples that can be done to assist. Aging. The epidermal layer becomes thinner due to metabolic and systemic changes during aging, and there's several alterations in the inflammatory response of older people. There's delayed leukocyte migration to the area, decreased macrophage phagocytic activity, and reduction of the growth factors cytokine release during the inflammatory response. So aging people usually present with delayed reepithelialization, delayed angiogenesis, and a decrease of fibroblast activity and collagen remodeling. For this reason, we should be aware and predict that the healing is going to take longer. We should also treat fragile aging skin with caution and handle it gently. Use non-adherent to low-adherent silicone dressings, and always take care with the correct application and removal to prevent further skin damage and further delayed healing. Nutrition. We have vitamin C and carbohydrates that are responsible for collagen synthesis. Vitamin A that improves keratinocyte proliferation. Omega-3 fatty acids that modulate the arachidonic acid pathway and cell membrane synthesis. Proteins and amino acids such as arginine, cysteine, methionine, and glutamine control collagen synthesis and modulate the immune cell activity. Zinc is a cofactor for DNA and RNA biosynthesis and has an essential role in cell proliferation. Iron acts as a cofactor in the synthesis of collagen. Iron deficiency impairs the remodeling of the ECM, the extracellular matrix, and has an important role in oxygen transport and hypoxia as part of the hemoglobin molecule. So what happens, and particularly in Africa, we see this with kwashiorkor, when there's various minerals and these fatty acids, etc., are deficient. Well, it prolongs inflammation, there's decreased angiogenesis, phagocytosis, and fibroblast metabolism. So it prolongs the extracellular matrix remodeling, and this leads to impaired healing as well as delayed healing, and we can predict it's going to take a lot longer until we get these minerals or vitamins, etc., replenished. The levels of these nutrients can be screened very easily with hematology. Medication, the well-known corticosteroids, we know that affects wound healing. The systemic anti-inflammatory effect of the steroids decreases cytokines and growth factors and fibroblast proliferation. We have non-steroidal anti-inflammatory drugs. And how many times do you see patients that have taken NSAIDs off the counter and yet they arrive with a wound that hasn't healed for 5 years? And the reason being is that they decrease the fibroblast proliferation, and that reduces wound retraction and delays the angiogenesis, which impairs healing. Chemotherapeutic medications decrease cellular metabolism and proliferation. This decreases reepithelialization, angiogenesis, collagen synthesis, and wound retraction, which delays healing, which is often the reason for only commencing chemotherapy once the wound management has been done and the wound is healed. Hypoxia, and I know there's a speaker going to speak later on this. This is really a problem because the correct balance of oxygenation is required for wound healing to take place and to prevent wound infection. But although a decrease in oxygen supply occurs on injury due to the vascular disruption, which is normal, it provides for the release of mediators that synchronizes angiogenesis, reepithelialization, and cytokine and growth factor synthesis. Hypoxia then leads to the synthesis of pro-inflammatory cytokines and ROS, that's your reactive oxygen species, and this in turn delays healing. Infection is one of the most common causes for delayed wound healing. Phagocytic activity of leukocytes leads to the bacteria releasing the endotoxins, and that results in local necrosis and inflammation due to the increase of these pro-inflammatory cytokines, higher MMP activity, and decrease of the growth factor release. So reepithelialization with infection, delayed wound retraction, and tissue remodeling are impaired by this chronic inflammation. The management is to prevent infection, prompt identification and diagnosis with appropriate infection management. And you can actually download free of charge the IIWCC 2022 document I mentioned earlier, which is the international consensus document on managing wound infection in clinical practice for further information. Stress and pain is included in stress, anxiety. They're lifestyle factors and they cause dysregulation of endocrine hormones. Acting in the nervous system and hypothalamus, stress increases the release of epinephrine, norepinephrine, cortisol, and glucocorticoid hormones. This triggers a decrease of cytokine release and leukocyte immune response, causing impairment of the inflammatory mechanisms and delays wound healing. One should consider referral for psychological counseling for stress management, anxiety, panic attacks, and manage pain effectively. Smoking, the big one, smoking. Well, we know that this increases the risk of several diseases, never mind decreasing wound healing. The compounds, for example, nicotine and carbon monoxide, decrease fibroblast migration, proliferation, and collagen remodeling, which all impairs wound healing. Hypoxia is one of the major mechanisms for delayed healing. Smoking also decreases the proliferation of erythrocytes, oxygenation, angiogenesis, and blood flow. In fact, did you know that after smoking one cigarette, it causes vasoconstriction for 90 minutes thereafter? Now, why would anyone smoke? Imagine what's happening to the blood flow in chain smokers. Smoking also increases the risk of thrombosis and embolism due to increased adhesiveness and platelet aggregation. Smoking influences the immune system, decreasing neutrophil, macrophage, and lymphocyte activity, which increases the risk of infections. So our management here is to counsel on the benefits of cessation of smoking, remembering it's a substance addiction. They need treatment to come off smoking, or at least counseling. We need to empower our patients to stop smoking. Please note, though, nicotine patches and nicotine gum should not be used whilst the wound is healing, as these can interfere with the wound healing itself. Alcohol suppresses the host immunity and increases risk of infection. It creates an hypoxic environment with free radicals and oxidative stress molecules. It also decreases collagen synthesis, altering the concentration of MMPs and impairs remodeling. We need to refer if the patient requests assistance to stop drinking alcohol. As we know, it needs to be volunteered by the patient. And a very interesting one, our sex hormones can predict healing. And we've seen this already in the prognostic factors of males being a predictive factor of delayed healing. And that's due to androgen hormones, being testosterone and 5-alpha dihydrotestosterone, as these have a chronic inflammatory effect, delaying the healing process by increasing inflammatory cytokine levels and leukocyte migration. So the higher the testosterone, the greater the prediction of a decrease in wound healing. In contrast, estrogen molecules influence keratinocyte and endothelial cell proliferation and migration, and they increase the rate of re-epithelialization and angiogenesis of wound healing. Estrogen shows anti-inflammatory activity through a decrease of leukocyte infiltration and pro-inflammatory cytokine release. So are healthcare practitioners, you and I, contributing to delayed wound healing? Well, it's published that in rural areas of developing countries, poor hygiene, as well as the lack of healthcare practitioner knowledge, frequently causes delayed healing. But coming closer to home, the Burden of Wounds study, GEST, in the UK, highlighted 25% of patients with chronic wounds did not have a differential diagnosis, indicating clinicians are challenged with holistic wound assessment, contributing to delayed healing and complications. And 25% of our patients, a quarter of our patients, don't have a differential diagnosis, which means that we're not managing them correctly, and therefore we can predict delayed healing. A scoping review in 2023 found that local factors were the best predictors of healing, as mentioned earlier, being wound duration, wound area, and wound location. This is the list of prognostic factors. It's interesting to note and be sure to include these variables in your comprehensive assessment. We need to assess, and reassess. So, now that predictive healing and factors effective healing have been discussed, and in conclusion, how do we transfer this knowledge to the bedside? Well, a systematic, initial, and ongoing thorough patient and wound history and assessment cannot be overemphasized. It's so important. Early identification of risk of delayed wound healing, prompt and aggressive intervention before complications occur to improve patient and wound outcomes, reducing morbidity and healthcare costs, especially pre-surgery. We can actually prevent this from happening. We need to diagnose appropriately, get that differential diagnosis, and address the underlying systemic metabolic as well as the lifestyle factors For instance, peripheral arterial disease, infection, your alcohol abuse, and all the other prognostic factors we've mentioned. We need to rule out malignancy in the chronic wound, as we know that this will definitely have delayed healing, and implement wound bed preparation to address the wound environment for tissue repair to take place. We need to review and refer if delayed wound healing is observed, and we should review at every wound consultation, every 2 weeks for infection, for the antimicrobial rule, if we need to change treatment. I thank you for your time and attention, and I'm happy to take any questions.
Thanks, Trish. That was fantastic. Worth waiting for.
Sorry.
And I think it just reinforces just the importance of that robust holistic assessment, isn't it? I think, unfortunately, you know, there's because of time restraints and all the rest of it, there seems to be just a focus on the wound itself, but there are so many factors. And it was fantastic that, you know, you're giving that rationale as to why that's important. And it's about that curiosity, isn't it, when we assess why is that important? But rather than sort of waiting for weeks or months to realise that wounds aren't healing, if we just got that right at the outset and looked at those risk factors, I think we'd be in a better position, I think. Just in terms of time, if it's okay with you, Trish, I can't see any significant questions at the moment, but if you have any questions for Trish, do you want to put them into the chat? And maybe if it's okay with you, Trish, could you maybe respond to those via the chat function? And then
Yes,
we'll try and keep to time then. Is that okay? But
with
thank you so
pleasure.
much. That was an absolutely fantastic presentation. I really appreciate your time. Thank you very much.
Absolute pleasure. Thank you.
Thank you.